So today I'm going to present our project, which is about socioeconomic inequalities in mortality and the underlying mechanism of these inequalities among older Australian men. I will start my presentation with a short background. Social inequalities in health defined as systematic disparities in health status of groups with different levels of underlying social advantage or disadvantages, including wealth, power, and prestige. Mounting evidence suggests that socioeconomic status, or SES, is one of the strongest predictors of death from all unspecific causes. However, the association between SES and mortality among older people is debated, with some previous studies finding an SES mortality gradient at older ages and other studies finding no associations. Behavioral risk factors such as heavy drinking, smoking, physical inactivity, and unhealthy diet have been proposed as one of the underlying mechanisms explaining SES inequalities in mortality. However, among men, this is not clear. Among middle-aged individuals, however, a recent systematic review of observational studies showed that health-related behaviors explain 20 to 26% of SES inequalities in mortality. But we don't know the mediating impact of health-related behaviors among older individuals. Social relationship and psychological distress or psychosocial factors could also be one mechanism underlying socioeconomic inequalities in mortality. It has been shown that structural and functional social support, as well as psychological distress, are related to an increased risk of mortality. Moreover, individuals with low SES are more likely to have low social support, to be less socially integrated, and have higher risk of anxiety and depressive symptoms. But there is little evidence exists with mixed results regarding the mediating role of psychosocial factors in SES inequalities in mortality among older men, older people in general. Due to this limited evidence and mixed results, the aim of our project was first to investigate the association between SES and mortality, second, to investigate potential mediator effects of health-related behaviors in SES mortality association, and the last objective was to investigate potential mediator effect of psychosocial measures in SES mortality associations. To do this, we use data from the Concord Health and Ageing in Men project, or CHAMP, which is an ongoing population-based cohort study in defined urban geographical region in Sydney. The study established in 2005 by recruiting 1,700 men aged 70 and over. The only exclusion criteria at baseline were those who were at residential aged care facility. The study has 4 follow-ups. For the purpose of this project, we will use data from the first, second, and third follow-up. The exposure variables for this project were socioeconomic indicators, 4 self-reported indicators of SES related to early adult life and to older ages were used, including educational attainment, occupational position, source of income, and housing tenure. Educational attainment is an SES measure that includes both early life and young adulthood. Occupational position is the most commonly used measures of adult SES, and sources of income and housing tenure are measures of current SES. So educational attainment were assessed based on the highest qualification, highest educational qualification, and were grouped into low, no post-schooling qualification, intermediate and high, university degree. Occupational position were categorized based on Australian and New Zealand classification of occupation into low, intermediate, and high. Sources of income also categorized into low, intermediate, and high. High are those that who have not reliant on government pension, and low are those who are solely reliant on government pension. And housing tenure divided into owners and others. Moreover, to assess the dose response of cumulative exposure to low SES, we calculated a cumulative SES score from these 4 individual indicators of SES. To calculate this score, educational attainment, occupational position, and sources of income coded 0, 1, and 2, and housing tenure was coded as 0 and 1. Thus, the cumulative SES score ranged from 0 to 7, and higher score corresponding to the greater disadvantages. Our outcome variables were all-cause mortality and cause-specific mortality. Consenting participants were successfully traced and followed up for all-cause mortality and cause-specific mortality through the New South Wales Registry of Birth, Deaths and Marriage. All-cause mortality were followed up to December 2017, and cause-specific mortality up to December 2015. We considered cardiovascular mortality, cancer mortality, and non-cardiovascular or CVD and non-cancer mortality as other mortality in this project based on international classification of disease. And I just wanted to mention that in non-CVD, non-cancer mortality, the most common deaths were from disease of respiratory system, disease of nervous system, and external causes. Regarding the potential mediating factors, we used data which were assessed longitudinally at first, second, and third follow-ups. For the second objective, the potential mediating factors that we considered were smoking, alcohol consumption, physical activity. We also considered body mass index as one of these mediating factors. For the last objective, the potential mediating factors that we considered were social relationship and psychological measure. We had data for both a structural aspect and functional aspects of social support. For structural aspects of social support, we included marital status, living arrangement, both living alone and live with children, number of family and non-family members, family support, which we divided to none versus having one or more family or non-family support. Social interaction score were based on 3 items of Duke's Social Support Index, and these 3 questions were about the number of times that participants spend with someone that they do not live with, or the number of times that they talk with someone, and the number of times that they attending social meetings in the past 4 weeks. And social satisfaction, which is the perceived measure of social support, were assessed based on 7 items of Duke's social support measures. And this could range from 0 to 21, and social interaction score could range from 3 to 9. Psychological measures that we included were depressive symptoms and anxiety symptoms. Depressive symptoms were measured based on geriatric depression scale, and those who scored 5 or more were considered as having elevated depressive symptoms, and anxiety symptoms were measured based on Goldberg anxiety scale, and again, those who were scored 5 or more were considered as having elevated anxiety symptoms. We excluded participants who did not agree to mortality data linkage and those with missing SES and covariates data at baseline. We conducted imputation for missing potential mediating factors at baseline and follow-up data. And the result that I'm presenting today is based on imputed data sets. We use Cox proportion hazard regression to quantify the association between SES and mortality, or potential mediating factors and mortality. For all-cause mortality, we estimated the hazard ratio and 95% confidence interval. And for cause-specific mortality, we used the Fine and Gray's competing risk survival regression, and we calculated subhazard ratio and 95% confidence interval. And for the purpose of this presentation, I'm only showing the association between cumulative SES score, which we modeled as tertile groups with mortality. So I will not present the association for individual indicators of SES. Most of the models were adjusted for age, country of birth, and living arrangement. The mediation effect of each risk factors on the cumulative SES mortality associations was determined by the percent attenuation in the beta coefficient for SES after inclusion of each risk factors one at a time and then simultaneously. The name of this method is change in estimates method. And we also take into account the assumption for this method. We also conduct 2 sensitivity analyses to assess the robustness of result. We repeated our analysis using data from those participants who did not have any missing data or complete case analysis, and moreover, to investigate the potential influence of reverse causality, that is baseline presence of diagnosed and undiagnosed comorbid condition, which may influence SES. We repeated the analysis after excluding participants who died during the first 2 years of follow-up. In this table, you can see the baseline characteristics by cumulative SES. After excluding participants based on our exclusion criteria, we include 1,527 men with mean age of 77 plus minus 5.5 for our analysis. Participants in the low SES group were more likely to be non-Australian born than participants in the high SES group. Regarding health-related behaviors, overall those in low SES group were more likely to be a current smoker and be physically inactive, but were less likely to be harmful alcohol drinkers. And regarding structural and functional social support as well as psychological distress, participants in the low cumulative SES group tended to live with their children, to have no non-family support in the area, to have lower social interaction and satisfaction scores, and to have elevated depressive symptoms. Now I will show you the result regarding the first objective, which was to investigate the association between SES and mortality. This table presents results of age-standardized mortality rate in our overall sample and across tertile groups of cumulative SES score during a mean follow-up time of 9 years plus minus 3.5 years. 783 deaths from all causes occurred. As you can see, there is a clear social gradient in all-cause mortality across tertile group of cumulative SES. This is the same table as before, and now you can see the result regarding cause-specific mortality. There were 197 deaths from CVD, 215 deaths from cancer, and 218 deaths from non-CVD, non-cancer during 8 years of follow-up. And as you can see, there is a social gradient in death from cardiovascular and non-CVD, non-cancer mortality across tertile group of cumulative SES. This figure shows association between individual SES indicators as well as cumulative SES indicators and all-cause mortality. Low educational level was associated with mortality. Being in intermediate and low groups of occupational position and sources of income was associated with higher hazard of all-cause mortality. No associations were evident for housing tenure and mortality, and there was a statistically significant inverse dose response associations across tertiles of cumulative SES and all-cause mortality. Now you can see the result regarding the association between SES indicators and cause-specific mortality. I try to highlight the association for you to be more easy to follow. So as you can see, low educational level was associated with CVD mortality, but not cancer and other mortality. No association were evident between occupational position and cause-specific mortality. There was an inverse dose response association between sources of income and cancer and non-CVD, non-cancer mortality. No association were evident regarding housing tenure and cause-specific mortality except for non-CVD, non-cancer mortality. And there was an inverse dose response association across tertiles of cumulative SES and cause-specific mortality except for CVD mortality, which the P4 trends was not significant. Now I will move forward to objective 2, which was to investigate potential mediator effects of health-related behaviors in SES mortality associations. First, in this table, you can see the result regarding the associations between health-related behaviors at baseline and mortality, as well as body mass index. As you can see, harmful drinking was not significantly associated with mortality, either all-cause mortality or cause-specific mortality. Current smoking and physical inactivity were associated with increased all-cause and cause-specific mortality. Being overweight or obese was associated with lower all-cause and cause-specific mortality, except for deaths from cancer. In this table, in this figure, you can see the mediating role of health-related behavior as assessed longitudinally on SES mortality associations. So this figure comprises of 4 different figures, which is 1 for all-cause mortality and 3 for cause-specific mortality. Model 1 was adjusted for age, country of birth, and living arrangement, and we included 1 health-related behavior at a time and then simultaneously into this model. And as body mass index was inversely associated with mortality, it will cancel out the impact of the 3 other health-related behaviors. So we will focus on the model that has alcohol, smoking, and physical activity in it. And before I explain the result, I want to highlight that the hazard ratio and subhazard ratios reported in these 4 figures are for lowest versus highest tertile of cumulative SES score. Overall, as you can see in the figure 1, the 3 health-related behaviors combined explain 21.5% of the association between cumulative SES score and death from all causes. For CVD mortality, the corresponding attenuation was 17%. For cancer mortality, this was 25%, and for non-CVD, non-cancer mortality, it was 11%. And as you can see, smoking contributed the most to the SES inequalities in mortality, ranging from 2 to 18%. Now I will present the result for our final objective, which was to investigate potential mediator effects of psychosocial measure in SES mortality associations. In this table, you can see the association between cumulative SES and psychosocial measure, which we use multivariable logistic regression. We have 3 different models in this table. Model 1 were adjusted for age and country of birth. Model 2 were further adjusted for health-related behaviors, and Model 3 were further adjusted for self-rated health. And if you look at the last column for Model 3, you can see that after fully adjusted for all the confounding variables, a cumulative SES score was associated with lower structural and functional social relationship and elevated depressive symptoms, but not anxiety symptoms. In these figures, you can see the psychosocial, the association between psychosocial measures and mortality, all cause and cause-specific mortality, and we have the 3 models, same as the previous table. And as you can see, being unmarried and living alone were associated with higher risk of all-cause and CVD mortality. There were no association between living with children or not having family or non-family support with mortality. There was a statistically significant association between low social interaction score and mortality, except for cancer mortality, but no association were evident for social satisfaction score. Elevated depressive symptoms was also associated with all-cause mortality and cause-specific, except for cancer mortality. There were no association between anxiety and mortality in Model 3 after fully adjusted for other confounding variables. In this table, again, you can see the result regarding the mediating role of psychosocial measure as assessed longitudinally on SES mortality inequalities. Same as before, we have 4 figures, one for all-cause mortality and the rest for cause-specific mortality. Model 1 is adjusted for age and country of birth. And then we added all structural social support measure. And then we have a model only further adjusted for functional social support measure. And then combine a structural and functional measure and psychological distress separately, and then fully adjusted model on the bottom. The association of, before I highlight the result regarding the attenuation, if you look at this figure and this figure, you can see the association of cumulative SES with all-cause mortality and non-CVD non-cancer mortality remain statistically significant after adjustment for time-varying psychosocial measures. Overall, social relationship and psychological distress could account for 35% of association between cumulative SES score and death from all causes, 29% for CVD mortality, 12% for cancer mortality, and 39% for non-CVD non-cancer mortality. And you can see that psychological distress was the most important contributors to SES inequalities in mortality. So in a representative sample of Australian men aged 70 and over, SES indicators related to early adult life through older age were significant predictors of all-cause mortality and cause-specific mortality over almost 9 years of follow-up. We also showed that the role of health-related behaviors in explaining SES disparities in mortality was modest. The reason for the weak to modest impact of health-related behaviors in SES inequalities in mortality is probably related to the cultural dependence of social patterning of these factors, as well as demographic characteristics of participants. We also showed that social relationship and psychological distress accounted for more than 1/3 of SES inequalities in death from all causes, CVD and non-CVD non-cancer, and for 1/5 of SES inequalities in cancer mortality. Other potential mediators of SES mortality association are differential access to health care and childhood SES. This study relied on a relatively large representative sample of community-dwelling Australian men aged 70 and over, with a long follow-up period and high-quality record linkage. And another strength of this study was the use of repeated measure of health related behaviors, body mass index, and psychosocial measures, which allowed us to consider changes over time. Regarding limitations, the CHAMP study is based on older men, and so result may not be applicable to older women or younger adults. Measurements error are inevitable when subjective measures of health-related behaviors and psychosocial measures were used. And I need to highlight that dietary behavior were only measured in wave 3 of CHAMP study. Thus, we could not include dietary behavior as one of the health-related measures in our project. However, we used body mass index, but there is debate regarding considering body mass index as a health condition or behavioral risk factors. But we used body mass index as a proxy for nutritional status, as it has been done previously in some of studies. To sum up, we demonstrated that low SES, especially sources of income and cumulative SES score, was associated with mortality. Health-related behaviors only partially mediated the SES mortality associations. Social relationship and depressive symptoms were associated with overall excess mortality and deaths from CVD and non-CVD non-cancer. And about 35% of the excess mortality among socioeconomically disadvantaged older men could be attributed to social relationship and psychological distress. These findings suggest that SES inequalities in mortality could at least partly be avoidable by implementing targeted interventions or policies with the aim of improving social relationship and psychological distress in disadvantaged older people. Thank you so much.